So good evening. Hello, everyone. I'm glad today, while we are thinking pink on October and renewing our commitment that no one suffering from cancer should be left behind, and renewing our commitment for cancer prevention and campaigning with this global effort, advocating for policy change, educating public, and empowering survivors to get the maximum of their need and to enjoy their life. I'm happy today to have a distinguished guest. I'm glad to be with a true public health figure, true women leader, that their contribution in public health went through the region and their countries toward the global. So we are proud to have this distinguished guest representing the women in the region in a way that influence the overall public health movement. And today we are through this webinar, we are going to discuss the breast cancer, and as part of this campaigning of October, to show the multiple dimensions that we need to address in order to prevent cancer, but also to provide the maximum care and right for cancer patients in our countries and in the region. So starting from the overall policy level, interventions, the power of community, and also taking some examples from the region to show our experiences and challenge and how we overcome this challenge. So I will start with Dr. Lamia, and I think Dr. Lamia will be a good start. She will be presenting from her seat as a regional advisor for cancer prevention in WHO EMRO, but also she came with a wealth of experience working for women health and also for NCDs. So she have this mix of experience. Dr. Lamia worked for the Minister of Health Sudan in different positions, technical and managerial, and she joined WHO in 2012. She had the experience in working in a diverse of country. We have countries, middle income, fragile country, and high income country. So she worked in Pakistan, Oman, Sudan, and then she joined the regional office. So I think this background position her in a good position to present. So we are going to listen to Dr. Lamia taking us through the burden, the region, the challenge in the region, and what's the policy need to be changed in order to address breast cancer, which is one, I think this is the highest woman cancer that we witness in our region, with variety of burden in the countries, but the overall picture that this is one of the challenges that we are facing. Dr. Lamia, floor is yours.
Assalamu alaikum. Good afternoon, everyone. And thank you to Infinite, and special thanks to you, Dr. Nada, for this invitation. And thank you for joining hands in commemorating October. So let me share my screen, and please confirm that you can see it. Are you seeing it in presentation mode?
Yes, we can.
Yes.
Perfect. So I'll be speaking about breast cancer in the Eastern Mediterranean region, from where we are in terms of burden, the policies that support our work, and how can we move to action. And as Dr. Nada mentioned, the theme for this year's Breast Cancer Awareness Month, no one should face breast cancer alone. And indeed, we really need to empower and support women with breast cancer, give them the support, psychological, emotional, support that they need, offer them patient-centered care so that we're telling them that you are not in this fight alone. So, I'm moving, yes, and talking about the burden. The data on GlobalCan tells us that somewhere in this region, a woman is diagnosed with breast cancer every 4 minutes. And every 11 minutes, a woman dies due to breast cancer. A mother, friend, a daughter, sister, they all count. And this tells us that the burden is indeed enormous. In our region, breast cancer is the highest cancer in terms of incidence and mortality among all cancers. So with an incidence of 40.3 per 100,000 population, in this region, we actually, translating that into actual numbers, is 130,000 women lost to breast cancer, in 2022. And in terms of mortality, 17.2 per 100,000, this tells us that 53,000 women died due to breast cancer in 2022. And without action, these figures are going to double by the year 2040, and therefore it's high time that our policymakers took action and acted now. So here, I'm just giving you more in-depth insight of what the situation of breast cancer in the region is like. So on the left side, the blue shows us, the map in blue shows us the age standardized incidence rates. And on the right, you see in orange, the age standardized mortality rates. And I think when you compare the two graphs, what is most significant and what strikes is where we have that survival gap, where we have the high mortality to incidence ratio. And you can see that for some countries, the color on the right is even of a deeper shade, even when it is not so deep on the right. So these would be countries like Somalia, like Djibouti, like Sudan, Pakistan, and Afghanistan. There is indeed a huge survival gap in these countries. And just hot off the plate is the WHO investment case of women's cancer that was conducted in the Eastern Mediterranean region. We put it up on our website just last Tuesday. And the link, as you can see on the bottom of the slide. And this was actually done to focus on two cancers, not only breast cancer, but it also addressed cervical cancer, in line with the integrated woman cancer approach that the WHO is now taking, allowing us to capitalize on the investments that we can put in place for women. So the investment case, I'll just very briefly tell you that it has two components. It has a situation analysis and an economic analysis that intend to provide the economic argument that will convince our policymakers that they do really need to act and that there are cost-effective interventions that they can act on. And the information that was used to develop this the situation analysis was through focal points nominated by the Ministries of Health, and the economic analysis, of course, was done by a health economist. And it really tells us the burden and tells us what are the returns on the investment. And I'm not a health economist, but the figures do tell us that breast cancer and cervical cancer impose a huge economic burden. And just looking at the last figure on the left, it tells us that within the next 20 to 30 years, they will cost, breast cancer will cost the economy $408 billion US. And what the government see is not the whole story. They only see 3% of these costs, which are the direct healthcare costs. But the much bigger component and more significant is the indirect costs, the societal costs, which account for the lost productivity. They account for the premature death, the loss of a woman to society, to her family. And just yesterday, I was looking at a study that was saying that people who have a cancer diagnosis actually lose all their savings. 52% of people who received a cancer diagnosis in the last 2 years lost all their life savings. So it really shows the financial hardship that is imposed by cancer diagnosis. And breast cancer can act as a tracer for many other health priorities and can help countries by acting on breast cancer. They can help advance and move towards the political commitments that they have made to a variety of other health issues. The work towards universal health coverage, towards women's health, towards non-communicable disease. And you can see here, it shows how breast cancer can actually contribute to many World Health Assembly resolutions that the world has committed to, and many of our policymakers in this region have also committed to. And in line with this, WHO has the guidance that will help policymakers actually move towards addressing breast cancer. In 2021, WHO launched the Global Breast Cancer Initiative, which has the objective of reducing breast cancer mortality by 2.5% per year. And that is with the aim of averting 2.5 million breast cancer deaths globally by the year 2040. And it can be done. Studies from high-income countries and from countries who have made progress in breast cancer have really shown that countries can actually make this 2.5 annual reduction. And to do this, WHO has put in place 3 pillars with 3 KPIs that will help countries measure their progress towards these 3 pillars. So the first pillar focuses on the pre-diagnostic interval, the early detection. And through the GBCI, we aim to achieve that 60% of breast cancer cases are diagnosed in stages 1 and 2. The second pillar focuses on the diagnostic interval, which is the diagnostic workup. And here we aim to see that every case gets a definitive diagnosis within 60 days of presenting for healthcare. And the third one focuses on the treatment, which includes the multimodality treatment and ensuring that there is no treatment abandonment and, of course, palliative care. So let me just focus on the first one, the 60% diagnosis at stage 1 or 2, which is, of course, very critical for our region. And I want to focus on that because we do have a huge component that is not really yet there, the public health education. Women need to be informed. Not women only, women and their families. Let me correct myself. Women and their families need to be informed of how they can address breast cancer, or they can prevent breast cancer. Or, well, let me say breast cancer, not a lot of it can be prevented. We have around 10% that could be hereditary or related to familial, but most of it is related to breast, to preventable issues, lifestyle modifiable risk factors. I think the one that has the hugest effect is alcohol consumption. And this is a risk factor where we do not really have to worry about a lot in our region. But then there are many other risk factors that women need to be aware of. Most importantly, women need to be informed that they need to do breast self-examination. A woman can usually do that. For example, 1 week after her period, she can set a certain date and routinely undertake breast self-examination on that day. Or even postmenopausal women, they can set a specific day every month in which they do the breast self-examination. Secondly, there's a health system component, the professional training. We need our healthcare providers to be informed, to be tuned, that whenever a woman comes, they take the opportunity to assess her clinically. They do a clinical breast examination. And in those settings where it's possible, they can do mammography screening. But this is not, although it's the gold standard, but it's not what we would want every country to do at the expense of diagnosis. And once a case is found to be positive, we go to the next stage of diagnostic workup. If nothing materializes, she goes back and then really do the same issues related to the pre-diagnostic interval. And here, I think it comes on more clearly. I just want to highlight to everyone, that's one thing that I always like to clarify. When we talk about early detection, we talk about 2 components, early diagnosis and screening. And we see that many countries are so interested in screening that sometimes screening is done at the expense of early diagnosis. We do not want to see that happen. We want to be sure that with the compromised health systems that we have, we give more priority to early diagnosis. Breast self-examination, clinical breast examination could also be ways where we can ensure that we catch the breast cancer early. And as I mentioned earlier, the investment case shows us the implementation status in the WHO EMR countries. This is as was provided by the Ministry of Health focal points who were part of that examination, of that exercise, sorry. So when we say the country has an organized program, it means that they have a very organized system with a poll and recall system. They have a defined target that they're looking at. But that is not always the case. And as you can see, most of our programs in the region are opportunistic. This is a slide maybe some would like to look at more, but for the sake of time, I'll go and I'm sure the presentation will be shared with you. I just also want to highlight the criteria that you see on the far right of the screen. And we see that in many countries, people go for screening at a younger age because there is this perceived notion that breast cancer is happening in younger women. It could be happening, and there are more women presenting at that younger age. But if we look at it statistically, it is because we have the biggest cohort of women in these age groups that, for example, the 30 to 40 or 40 to 90, more women are in that age group. But if you look at it, and that's why we're seeing more women in these ages with breast cancer. But if you look at it in terms of numerator and denominator, you will know that it is not that much significantly higher in these age groups. And therefore, WHO still recommends mammography from the age of 50 to 69.
Dr. Lamia, sorry for interruption, but if you can increase your voice, I received some comments that, yeah.
Okay, I'll try to shout. Okay.
Yes. Yeah, that's okay.
I'll have to wrap up. But I am indeed almost wrapping up. So let me just very quickly talk to the other two pillars, diagnostic interval, which I mentioned, and the treatment interval, and link it to the regional investment case that I mentioned. So the investment case tells us that every dollar invested in early diagnosis and comprehensive treatment for breast cancer brings a return of $6.4 to $7.8. That's the return on investment. So for every dollar, you get almost $8 return on your investment. And I think if we use such information wisely and in a good way and advocate and use it to inform policymakers, we might be able to change the mindsets and increase investments in breast cancer. So just my take-home messages is the fact that addressing breast cancer in the Eastern Mediterranean region is a public health imperative because of the diverse evidence that we have epidemiologically, the economic considerations that I have mentioned, and we do have existing political commitments. Cancer overall is becoming a political issue in the region, and we really need to capitalize on that political interest and try to encourage policymakers to take more action. Early detection is a must. If you want to downstage cancers, then we really need to focus on the early detection. And countries need to carefully consider what do they take from this package of interventions and how can they implement it within their existing capacities. We need to be very realistic. We need to make full use of the primary healthcare setup and using that because that is the entry point to the health system for many women. And we need to think of comprehensive management approaches that are effective, and that will show the return on the investment. Patient navigation is important, and now there's a lot of talk about that. We need to ensure that women do not waste a lot of time because they do not know where to go. And that is very common in our region. There are no clear pathways, no clear referral pathways for women, even after they start the treatment. So that is something we really need to work on. And WHO is now having technical working groups that are working on this. And just last week, we have launched the patient navigation guidance to everyone. And I'll just end with this last important message, which is the importance of partnerships and coordination. Nobody will be able to tackle this alone. Everyone has a role to play, and therefore partnerships and working together, the different entities, be they UN agencies, member states, the ministries of health, academia, civil society, and people living with cancer, especially women who are living with breast cancer, we all need to work together. The women living with breast cancer are a very strong and powerful advocates that we need to capitalize on. We need to engage them, get their thoughts and their inputs on how they would like to see services being delivered and how we can best meet their needs. I end with the quote, "No one should face breast cancer alone." This was today in our office when all our, well, not all of our staff, but all of those who could find something pink in their wardrobe made it and joined us for the group photo to voice their commitments that indeed no one should face breast cancer. Thank you so much, Nada, and back to you.
Yeah, a nice photo to end the presentation. And the nice thing that it's a male, female participation. So that indicate a lot that we have everyone working to support cancer prevention and to support cancer patient. And Dr. Lamia's presentation showed us that although there is a recognized high burden, there is a political commitment towards cancer, but still when it comes for the real implementation, there is a lot of challenge facing the early detection, fixing the patient referral, and so it's a it's both community and policymaker and expert contribution to overcome this challenge, and with the need for the community, I think it's time to introduce Dr. Ibtihal Fadil, and I think Dr. Ibtihal Fadil is a well-known person that I think it's difficult to introduce and also to summarize her experience. But just I want to show that Dr. Ibtihal is one of the public health figures who dedicated a lot of effort in compacting NCDs in general, and she is founding the chair for the Eastern Mediterranean NCD Alliance, and also she is leading the MENA Coalition HPV Alliance. She comes from a different background. So while she used to be the regional advisor, WHO EMRO for non-communicable disease, she also served supporting national government in Bahrain, in Iraq, in their strategic work, and from that position, Dr. Ibtihal moved to bringing the power of the community, the civil society, and she now leading the NCD Alliance. And definitely, we believe that NGOs, civil society, is the organized power of the community when it comes for discussing how this organized communities could influence the policy, but also empower the individual at community level. And the challenge become more, I think, harder when the issue linked with women, stigma, and gender-related issues. So we are going to listen from this, from Dr. Ibtihal on this perspective, to show the power of NGOs and civil society to combat and prevent breast cancer and shape the policy at the national level.
Thank you very much, Dr. Nada, and thank you for the Infinite for providing the opportunity to talk about breast cancer during Breast Cancer Month. So we've been very busy in our organization as a civil society and our member organization campaigning during this month for breast cancer. But we are not, we have done a lot of activity beyond beyond October, and we will continue also the campaign after October, because we, as Dr. Lamia said, we don't want to leave anyone behind, and we are very much affected by this public health major challenge, the breast cancer in our region. So let me start by just sharing with you one of the video which we use in our campaign. Before, I will not talk about burden or any figures, because this is already well said by Dr. Lamia, and everyone knows, like how breast cancer is #1 killer in our for women in our region. So let's share this video.
Breast cancer remains a significant global health burden, affecting millions of women worldwide. Ranking as the most commonly diagnosed cancer, it poses a serious threat to women's health. It is also the leading cause of cancer death among women, claiming countless lives each year. In the Eastern Mediterranean region, breast cancer accounts for approximately 25% of cancer incidence and 20% of cancer mortality among women, making it a major public health concern. Additionally, recent evidence reported that breast cancer incidence and mortality in the region are projected to double by the year 2040, unless major action is taken to reduce exposure to risk factors. Several factors contribute to the rising breast cancer burden in the Eastern Mediterranean region. For instance, tobacco use, namely shisha use among women, is on the rise in the region, along with a higher incidence of obesity-related sedentary lifestyles, limited physical activities. Moreover, the overuse of beauty products and hair products might be associated with increased incidence of breast cancer. The World Health Organization's Global Breast Cancer Initiative is a groundbreaking effort that aims to reduce the incidence of breast cancer by 2.5% each year. This ambitious goal, if achieved, would result in saving 2.5 million lives over 20 years. To achieve these objectives, we need to focus on 3 key strategies. 1. Health promotion and early detection. 2. Timely diagnosis. And thirdly, comprehensive treatment. The Eastern Mediterranean NCD Alliance is committed to working with WHO and countries to implement this initiative. This can be accomplished by advocating for policy changes to reduce exposure to breast cancer risk factors and strengthen the health system to improve early detection and comprehensive treatment. Supporting awareness campaigns. These campaigns can educate women on the importance of breast cancer screening and early diagnosis, ensuring that every woman has access to affordable and high-quality breast cancer screening and treatment services is essential, even in humanitarian settings. By addressing the rising breast cancer burden through a multifaceted approach, the region can work towards reducing the impact of this disease on women's health and well-being.
And I will share my slide with you. My talk will be complementary to Dr. Lamia, because we as a civil society, let me thank also Infinite working with us on this ground. We are focusing on, as a civil society, we are focusing on advocacy, raising awareness, engaging patient and community, because most of the civil society and specifically the NGO working on a ground root level. We are also involved in capacity building on a different section and program, and also many of the NGOs we are working with providing services for screening, early diagnosis and treatment of cancer. And also we add issue of accountability by providing numbers and progress on achieving the target. So specifically, the organization which I am chairing, the Eastern Mediterranean, is a network of over 50 civil society working in our region, including one related to tobacco control, cancer, cardiovascular, diabetes. And we are advocating, basically, our work is to advocate for including NCD in the national policy and program. We raise also public awareness and focus on engagement of people living with NCD, and also engage the community in NCD policy and development and execution of the policy. And we focus on creating more alliances and network And because this is facilitate the collaborative work and working together, having the same commitment and sharing the same goals and mission. You have asked me certain questions to answer. So what is exactly the NGO most effectively raise awareness about breast cancer and how you address the stigma? The stigma is a major issue, but I see that currently with time and more people, we have more survival or breast cancer who are coming and talking about their experience in breast cancer. It minimizes the stigma. And in terms of the awareness, we are doing all over the year, not only in October, all over the year, programs which is related to women cancer in general and breast cancer specifically, considering this is a public health issue in our region. So part of, there is a public education campaign, and also there is most of the organization and member we work with, they have one message to tailor to our region. And giving you example, like the breast cancer, Jordan breast cancer program, with other breast cancer program, they created alliance called the Arab Alliance for Breast Cancer, and they have unified their messages every year, which is very culturally sensitive messages. And I'm putting here examples like this one from the first one to the right, from our campaign, our meeting, and focusing on issue related to breast cancer risk factors and reducing risk factor, as well as education women on breast self-examination and so on. It's traditionally known that most of the NGO working with area of prevention. So every member organization work on obesity, physical inactivity, tobacco control, promotion of breastfeeding, promotion of healthy lifestyle, and also currently the reduced exposure to environmental risk factor. So these are all under the area of prevention of cancer, of breast cancer specifically. So whatever we call it modifiable risk factors, there is the non-modifiable, but at least the modifiable risk factor is the area where the civil society is working on successfully for years to improve the standard and reduce the risk factor for breast cancer in the region. Bringing the patient voice, we talk about stigma and lowering the stigma in breast cancer. We had done a survey on, among people who are affected and living with, some of them living with breast cancer. And we listened to their voices and also empower them. We did a training to empower them on how to articulate their stories and to be part of the support group for other survivors. And I also posted currently there is a lot of they call it the survivor graduation and the survivor dialogue were done by the Gulf Federation of Cancer Control and other like FOCP, and similarly in many other organizations who bring all breast cancer survivors to talk about their journey and story and so on. And this definitely minimizes the stigma related to breast cancer. How do NGOs view their role in breast cancer advocacy as a primary leader in the field or as a key partner? We see our role advocating for policy change, advocating for reducing the risk factor. All these, we are seeing our role as a key partner with WHO, with government, and with national entity, because civil society, they have the power and they have the position to support the implementation of all the strategy, which is evidence-based, developed by WHO. So we support implementation of this strategy by bringing community together. I can give some examples of work recently, like this is the breast cancer side event, which has been well attended by a higher level and give it from political leader from our region at the level of the ministers and also regional director. We have also used the opportunity of gathering of a policymaker in Geneva during the World Health Assembly to highlight and prioritize women cancer, including breast cancer. Similarly, in other events where cancer advocates are there, we use that opportunity to also highlight the issue of breast cancer and cervical cancer in our region. So we are considering, as a civil society, we're considering ourselves having a very a collaborative role and advocating for implementation of the evidence-based strategy developed by WHO. What role do alliances between the NGO and policymaker play in creating enabling environment for breast cancer care? All of you know that like countries who are suffering a crisis and war, like what happened in Syria, unfortunately, currently in Palestine, and in Iraq, Libya, and others. So we have centers in our region who are excellent center of excellence for care. They are part of civil society, because civil society is not only NGO, they include academia, they include the excellent centers of care like King Hussein Cancer Center and other center like AUB Center. So these are, they provide, they lobby and advocate for providing the care for people who are national affected by breast cancer, as well as the people who are coming from to be hosted in, like the people who are coming from Syria, Yemen, Iraq previously. All these people has been supported through the lobby and advocacy, which are led by our member organization, like the King Hussein Cancer Foundation, FOCB. They provide them with the support and the treatment and care they need. In addition to that, there is a lot of capacity building happen, and this is very important. As Dr. Lamia had mentioned, one of the key pillars in the strategy is to the screening, where we need to train a primary care physician on the issue of early detection and early diagnosis of cancer. So there is a lot of work which is civil society working in prioritizing within the policymaker and also providing the care needed by the people affected. I will skip this one related to cervical cancer, because we are also very proud that we are working in the agenda for HPV elimination, aligned with the strategy, the WHO strategy on cervical cancer elimination. Having said that, there is still many challenges which are currently undertaking, the work of the civil society, and also affected the performance of the health sector in our region. So the challenge of early detection, and we are, unfortunately, many cases are still presented in advanced stage, despite the continuous and the regular work of the different campaign by Ministry of Health and by the civil society, as well as the availability of different detection measure. Still, women are not seeking, if you study the uptake of breast cancer screening, it is still not up to that level in the region, and many cases are presented in advanced stage. Cultural sensitivity around breast cancer and women's health, and that is, as I said, this is a very diminishing now, with the more empowerment of the women and more engagement of women support group. There is a lack of a multidisciplinary approach in the treatment, and mainly in the country with limited resources. And the treatment cost, and especially in the country with the limited resources, we know the out-of-pocket expenditure for breast cancer is very high in certain country, and I hope, still there is a major contribution from some of the NGO who are supporting people who cannot afford the treatment. And the issue of data and electronic system is a major obstacle, especially cancer registry. And when we talk about cancer registry, we want to have a quality data with the stages to ensure the progress in terms of down staging of a breast cancer. Limited collaboration between various sectors, and this is very important. I had been alluded in the previous, Dr. Lamia had alluded to this, the importance of collaboration and partnership. So again, in a summary, what we want to see to improve the situation, the agenda of breast cancer in our region. We request the national authority in developing and executing the WHO recommended approach that has been well presented before, and focusing on breast cancer prevention as at least the modifiable risk factor we can modify and prevent. Early detection, I underline the early detection issue, because especially early diagnosis is not related to income or the level of resources. Any country in the region can do early diagnosis. And here, where we say capacity building for health professionals to improve early diagnosis. A primary healthcare professional have a major role in advancing cancer, and this is where the strength of a primary healthcare comes into play here. And countries who want to implement a organized screening program, they need to do in a way of pilot and then expand. The final point which I want to also to highlight is that the next meeting of the UN high-level meeting in 2025, which focus on non-communicable disease, including cancer and women cancer. And we want to prioritize in the language of the political declaration, the issue of women cancer to reduce the suffering. As you said, this is a tragedy for the family, for the society, for the individual, and for the development and for the income of the country. So we want to highlight the issue of women cancer in the political declaration. Thank you very much, and working together for effective control of cancer. Thank you.
Thank you, Dr. Ibtihal. Thank you. Very interesting. And to me, to see in our region where everyone gets shy in talking loudly about their own challenge, that we can see now an organized effort to empower patients, to talk loudly about their experience, about the suffer, and also the voices of patient whenever it's hidayah. It's also help in designing the service that is needed. I would like to maximize the benefit of the availability of Dr. Ibtihal before 6. So I just want to, you mentioned in your presentation that not till now we didn't reach that the utilization of the screening service. Well, it's not well utilized, although there is an opportunity. So for me, is it for us as a health professional promoting this screening program, we don't yet understand the language that we talk for the community to promote this screening. Is it that women are not trusting on the self-examination, all these simple things that they can get finding? Is it missed opportunities that the care provider mindset is towards responding to the symptoms rather than getting identifying cases, or what? How can we overcome this based on your experience.
Yeah, thank you for this question. It has been raised today in another meeting related to cervical cancer also. So the issue of screening is in the uptake of the screening has to do with many factors. One, it's not only the health system, it's the perception and belief of the community regarding the screening. And the other things is related to the health system readiness and availability of the infrastructure for the screening. Like if you take some of the country which already offering the screening and they have a good established health system to offer the screening, still they are reporting a very low intake of the screening. So I think it's a multifactorial or multifaceted issue, and this is why we need to work on both sides. We need to work to encourage the community to use the screening as available, and that is what is all the campaign doing. You know, the whole October, you see every entity, healthy entity, and civil society, and all of them, they are working and providing a campaign, and some of them they are providing a mobile vans to do the breast cancer screening. It's still, with all this effort, you see we are not reaching to a good level of uptake of the screen. Another challenge is the health system. There is a weakness in terms of the availability of infrastructure for the screening. So when we advise women in October to go for screening, the one who go for to do the screening, they face the issue of cost or the issue of delay in reading the mammogram, or not the test is not available, the mammogram is not available. So we cannot generalize, but we have to work on all these obstacles and to improve the screening. And this apply not only for breast, apply for all other screenings, cardiovascular, screening for diabetes, and all of them. The community has to understand the value and the importance of screening.
So this is the community, Dr. Ibtihal. When it comes for policymaker, I have discussion with one of the seniors in one Ministry of Health, and then he said like these loud voices encouraging for screening create a challenge for the ministries that they cannot provide a service. I mean, in terms of advocacy, focus. So just if you can just say 2 words before we go to Dr. Layla to listen for Jordan experience.
Yeah, I think if the system is not ready, still we have to make the women aware, because we know scientifically the difference between early diagnosis, you know, like when the cancer in early stages, and how it increased the survival tremendously for the women. So I mean, the argument is the system is not ready. We have to build that system. We have to make the infrastructure, because this is a very critical issue. It is the survival of the women, and early diagnosis and discover the disease early make a huge difference in her life. So we know now people who are diagnosed early in breast cancer, they can live 20, 30 years, and we have seen these cases. But late diagnosis is not acceptable. It's not acceptable. So we have to build the infrastructure to make the early diagnosis and screening is a priority.
Thank you, Dr. Ibtihal, for this insightful presentation and reflection. And today also you highlighted that academia is part of the civil society, which should not recognized when we talk about the civil society, just the picture jump for the NGOs and their role. So I think there is a lot of effort that academia could do also in terms of research, evidence, and continue evaluating the efforts that we had at the region, so we improve our policies. So just allow me to introduce Dr. Layla. And before introducing Dr. Layla, I just want to say, since I was working for the Ministry of Health Sudan, we keep hearing about King Hussein Center for Cancer Care, and how this center not only serving the cancer patient in Jordan, but also their service extended to serve as a care for many people coming from different countries, but also in terms of sharing experiences. There is a lot of, let us say, twin program that happened with other programs in other countries in the region. So Dr. Layla is a doctor of medicine. So she she had a wealth of experience in dealing with cancer patients, especially that currently she is leading the breast imaging unit in Kong Hussein Center. And she, beside having her career in this medical care, also she get diploma in leadership and management. So she have, like, the two dimension of managing, leading program, but also providing service and handling the patient. And today, Dr. Layla will reflect on King Hussein Center experience and how they overcome the challenge, the experience on providing both preventive and curative, contributing for screening, but also handling cancer patient, specifically breast cancer, and coming up with good outcomes of their service. So floor is yours, Dr. Layla.
Thank you very much, Dr. Nada, and I thank Dr. Lamia and Ibtihal for very, very nice talks. Actually, it's very interesting to hear all this in one session. Thank you for inviting me for this talk. So I will be talking about KHCC role in addressing the breast cancer care as in the situation in Jordan. My background is I am a breast radiologist. I am diagnostic imaging radiology, mainly specialized in the breast imaging and interventions. So we have to remember women and children and cancer patients in Gaza and in the world, but as you know, the situation, we have to pray for them. So I will just mainly focus about our KHCC work, the quality management, the comprehensive cancer care. But the beginning, we'll just give introduction about breast cancer in Jordan. So according to our cancer registry, which we are very happy also to have a cancer registry in Jordan and the KHCC, since 2022, this is the data. Jordan is a small country, as you know, and the population is small compared to other countries in the region, 11 million population. So there's a small, but the number of breast cancer cases, it ranges number one, almost 1,740 cases per year. And it is the most common. If we look at the next most common cancer is the colorectal. So the breast cancer is a burden, which already you talked about, but I emphasize this in Jordanian females. And also in non-Jordanian, as Dr. Nada mentioned, they are coming for treatment in Jordan. Breast cancer remains to be number one among these women. And among cases presenting to KHCC, which more than half the kingdom cases end up in Jordan, in KHCC, sorry, these are breast cancer. So how did it start? This is the trend of cancer, breast cancer in Jordan. And in 1979, almost started the idea of having the breast cancer center, which we have now, the King Hussein Cancer Center. So how was the journey? It started as named Al-Amal Hospital, or Al-Amal Center, actually, in 1979. With the effort of the people supported the idea of forming this one. And in the year 2002, it was changed after the late King Hussein, because he died of cancer, lymphoma also. So to avoid this taboo of calling the patient the word cancer, to avoid, not with that patient and people like to say the word cancer. So the King Hussein Cancer Center as a medical center, this was the idea in 2002. Almost 2003, there was a bigger establishment of the King Hussein Cancer Foundation, the institution which governs the medical part, us, the King Hussein Cancer Center, and the other part, which is the fundraising and the development. This is very important to get funding for this kind of institution for cancer care. So our part, the King Hussein Cancer Center, is part of the foundation. Our care is mainly the medical care, the quality care, the comprehensive cancer care. I will go through our journey at King Hussein Cancer Center in these fields. Equality management, this was the vision of the administration since the beginning. So it was the first institution in Jordan to obtain a certification from the GCIA. And once you get the certification by international body such as the GCIA, so now an important issue which also Dr. Ibtihal mentioned, like if you want to provide service, it has to be comprehensive service. So the approach we use for the cancer care is two important elements I highlight here. The multidisciplinary approach, having different team members, the radiology, the surgery, the oncology, all dealing with the patient. And we have also site-specific services. We have a breast cancer service, we have a bone marrow service, we have a leukemia service. This gives really a chance for the people to deal with the case and to cover all what you need to do. And there are focused people doing the services. There are facilities providing this one. For example, for the breast radiology, we are doing only breast imaging. And also to have a clinical practice guideline, to provide outline of the treatment to be unified for all patients. So how do you do this one? You have to include the spectrum of cancer care, and this is our strategy in the King Hussein Cancer Center. You have to be up to date with the newest technique, the guidelines, the trial, and to try to implement it in your center. And this, of course, needs training, needs to be aware of attending these courses, whatever, and of course, it needs funds to buy these instruments. Also, once you have, I always say it's not only the machine which is available, you have to have well-trained staff dealing with the machine, whether you are a radiologist, whether you are a surgeon, radiotherapist. And once you have the machine and the staff, you have to maintain this one by quality control of the machine itself, by the service it is, by doing the KPI, to follow up your service and how you are providing it. And this spectrum, it has to be done at all levels, starting from early detection, for example, for breast cancer mammography, and through the diagnosis step, treatment, follow-up during treatment, and also during the surveillance phase. So it has to be the spectrum, all steps of the cancer screening till the surveillance. For example, as a part of breast cancer imaging, like the diagnostic radiology, this is the part of diagnosis. The breast imaging services, the nuclear, the pathology, the genetics. We included the genetics services now at our center. So this is the advancement we're talking about and which you have to include to give the comprehensive service. This will lead you to comprehensive treatment plan. If you want to do with the surgeon to give the best surgical approach, you have to have the surgical techniques, the reconstructive surgery, radiotherapy. An advantage at our center, we added like the nutrition clinic, the fertility preservation clinic, bone health clinic. So also taking the patient as a whole during the treatment and during the follow-up. And this is like specific for the cancer care in our center. Beside the comprehensive, let me call it the clinical care, you need the supportive care, the psychosocial support, pain management team, physical rehabilitation. It's very important, like after surgery for the upper limb to avoid lymphedema, patient family education. So this supportive care also contributes to excellence of its treatment. I will just take our breast imaging unit as an example. And how did we expand over the years? We started in almost 2007. As I showed you, when the King Hussein Cancer Center was established, there was one mammography unit. And the idea was, with the support of establishment of the breast cancer program, to have a breast imaging unit where you can put the mammogram, ultrasound, and the team working in one place. And this was unique. It started in Jordan in our center, and it went on and on, even the region and other hospitals. With the progress and increasing time, you have to provide the comprehensive service. We added the intervention to our unit. So we're doing the best intervention in one space with the best imaging unit. With the increasing number of awareness and the screening, we had to expand as an early detection unit, which we have another place for this early detection clinic. So this was second two location for one service. We continued to have all the advances like MR guided biopsy, which is not available. It's like reference for the area. We improved our department. And of course, this is it needs, you have to have the vision to have this improvement and to work on it and to plan it. And now with the last expansion of the center, we have now 3 locations in the special center for the cancer patient and for their follow-up. So this is an example how you can expand a service for the cancer care, starting from 1 mammography machine to a comprehensive breast imaging unit with the 3 locations. And once I say comprehensive service, for example, in breast imaging, as I said, you have to have the state-of-art technology to provide for your surgeon, for your oncologist. He's want to do follow-up for neoadjuvant chemotherapy. You have to give him all the options he can utilize and being as part of team. You have to have a professional team, and you need a training for this one, of course, to be able to find the small cancers, as like in this case. Of course, an important component always, which enhance, sometimes you think that education and the training is very important as part of the clinical service, because this enhances the strength of the department, the units, all of it. We have different programs like medical education programs, residency program, fellowship programs, some diplomas, training programs. We continuously perform educations and training hands-on workshops. And some of these workshop hands-on to cover the whole area of Jordan, we come together with the Jordan Breast Cancer Program, we perform on-site hands-on workshops. So we will go to different cities outside Amman, the capital. We go to the north, to the south, and this was really, really very helpful. I'm talking mainly about the breast imaging, and wherever we go there, we give a general talk about the breast cancer screening, so that all the physicians working there, with even the general practitioner there, the family medicine doctors, they will come attend a general introduction, and then we'll focus about imaging. So these are like examples supported by the Jordan Breast Cancer Program and the King Hussein Cancer Center. Of course, our center realized the importance of cancer research, including the breast. And there's a great effort put now to emphasize and to give time and advantages to the people to work with research. So now we have an office, and this is also, I'd like to add this idea, that having special office taking care of each element is important. So now we have an Office of Scientific Affairs and Research, which is responsible for the cancer registry at our center, which is a very excellent one. The grants, we have institutional board review for the IRBs, we have a clinical trials. They're attempting to include our center in different international clinical trials. And one of the, I say, biggest achievements over the past 2 years is the announcement of the King Hussein Cancer Center Conference and research of the King Hussein Cancer Award, which encourages research in the region. Of course, if you encourage research in the region, you enhance the efforts of the people, you enhance their knowledge, how they can apply this in their own country, our region. Now, to talk about early detection and cancer prevention, as I said, we are the clinical part taking care of the patients, but also our part of social responsibility, let me call it, our community activities. We are working together as a breast unit, for example, with the early detection unit, where we have a clinical general practitioner, family doctors are taking care for the clinical exam. They do the pap smear. They send the patient for colonoscopy. Also, we have a clinic for this one. Together with the Jordan Breast Cancer Program, we are together trying to emphasize and work on the efforts of early detection. And another office here, which I did not talk about it lots, is the Cancer Control Office and Cancer Prevention. Like we have the smoking cessation. We have put excellent efforts in this field, and even went to the national level, that there are now laws applying that you have to stop smoking in certain areas. So definitely I have to come now to talk about the efforts of the Jordan Breast Cancer Program. So in 2007, it was established as a nationwide program. This is led by the King Hussein Cancer Center and Foundation, and together with the Ministry of Health. And here emphasizes the idea of collaboration between the bodies to achieve. And also the Jordan Breast Cancer also works with the military hospitals, with the university hospitals, collaborative efforts. The idea was mainly to emphasize, to focus on early detection efforts in the whole kingdom, to provide screening to Jordanian women, and focus on awareness and about the breast cancer. How do we do this one? We do it together with the Jordan Breast Cancer Program. We, as a King Hussein Cancer Center, we take part in these activities. The main bulk, as also Dr. Ibtihal mentioned, the Al-Hamla Al-Muwahhada, unified awareness campaign over the past maybe like 7 years in the whole Arab countries. to give one message together. So we are always participating part of this one. We have implemented the mobile van to reach remote areas and underserved women, and awareness and public education. As you can see, one of our lectures was targeted to women with limited hearing, with limited disability of talking disabilities. We had a volunteer with a sign language expert. So we tried to include all women and to reach in the remote areas with the limited disabilities to access them. And of course, October campaigns, we participate with them. Despite our clinical work, we try to give some time for these activities together with the Jordan Breast Cancer Program and the foundation itself. If I would like just to sum up our work at KHCC, like what is special about it, the comprehensive care, starting from screening to treatment to surveillance. So I always say this word: if you don't be able to follow your patient after you do screening mammogram, for example, as a breast cancer, so you don't want to do the screening. So you have to, if you don't have the service, you have to know where to refer your patient to have the comprehensive care. Of course, this comes to next steps of treatment, of surveillance. The comprehensive care with a multidisciplinary team approach is very important, which enhance making our center a distinguished center. And thank you very much. Thank you.
Thank you, Dr. Leila. Really great effort that King Hussein Center is doing, and providing a model of work in cancer, addressing cancer in general, and what you highlighted specifically for breast cancer. So just a few questions, Dr. Lamia. We saw the experience that we have this specialized center with all these capacities and multidisciplinary work, while we need to expand the network, reaching every woman in everywhere. And here the PHCC and primary healthcare and community service role become like a real need. So how can we integrate breast cancer and the balance also between the word approach of integration and providing a tangible service, a specialized service that could serve the purpose? And in your presentation also, you highlighted the challenge on referral and the new guidelines for WHO. So if you can elaborate on this, I think this one of the key challenges that the policymaker at the Ministry of Health always talking about. Yeah.
Thank you, Dr. Nada, and thank you, Dr. Leila. It's always impressive to hear the great work that is going on in King Hussein Cancer Center.
Thank you.
It's been setting a great example for the region, and we do always refer to your work when we are asked about best practices across the region. And indeed, I think you've spoken to the issue of the patient navigation. I really like that component and the fact that you do give it a lot of attention. I think the network of private healthcare in Jordan would also help greatly facilitate this, because I think one of the key challenges in our region is the issue of access to women in rural areas. The fact that you have this mobile service, the vans that you spoke about, I think that's an initiative. We see it in many parts of the region, in many countries, they're also doing that. The scale varies, of course, according to the capacity, according to what can be offered. And this is something that, by the way, we see a lot being led by civil society organizations. So the cancer societies in many countries across the region actually do help with this outreach screening service in many countries. But I think I'd just like to commend again the work that you're doing, and I think across all the region, we just need to also make sure that the systems link up in the best way possible, so that women do not suffer as they move from one layer of the health system to the next, not only in this direction, but also in the other direction, so that once they are on treatment, they also know they know where to go once they've completed the treatment. The survivors, if they really want to continue follow-ups, they would also need to know where they're expected to go and where they can find the service they require.
Yeah, and then Dr. Leila mentioned about the screening and giving. I think this is the area where you also one of the critical function that you are doing as part of the King Hussein Center. So we frequently hear from the women that the worries about, you know, the imaging, mammography for screening, the risk versus the benefit and all this thing. I have seen the interactive discussion in the Q&A, but also I would like giving you that specialized in the area to just give some reflection on that.
Thank you. First of all, you know, screening mammography was established. It is well known that it has a benefit. It's been proved to reduce mortality of breast cancer. Now, mammography by itself, like it is a radiation for the breast, but there's no data that mammography itself will induce cancer in the woman. So there's no data like this. It's like you say, doing mammogram is like traveling, for example, from Amman to maybe to New York by the plane exposed to the background radiation. It's the same dose of radiation which you get it. So this probably this is like we can call it a myth that maybe breast mammography causes cancer. But the issue with mammography that it has a limited value in certain group of women, like the dense breast issue. Women with dense breast. That's why the mammography machine was updated, and that's why I said like you have to include this model. For example, like the digital breast tomosynthesis. So together with mammography, you have to add additional step, maybe ultrasound. Maybe you have to add the digital breast tomosynthesis. In certain cases with high-risk patients, for example, you have to add breast MRI. And there's now like more techniques like the contrast mammography. So these additional steps will always increase cancer detection rate by at least 2 per 1,000 cases as compared to the mammogram by itself when you are doing alone. So maybe this sometimes like women will think that maybe breast cancer is hidden, not shown by the mammogram. There are reasons for this one, and there are solutions now for this one.
You're mute, Nada.
So if you can also, Dr. Leila, just add your or reflection on using artificial intelligence on your specialty. If
Yes.
you can highlight. Now it's trending everywhere, artificial intelligence coming like strongly as an alternative solution that has a magic to solve everything. This is the assumption. So how you see this?
Yes. Yeah, I have to. So artificial intelligence, I will still call it as an assistant. And probably mammography is the place where, before the artificial intelligence in its official form now, it was used called computer detection, the CAD. It used to help radiologists like to classify the finding of the mammogram. Probably artificial intelligence in mammography will help maybe in filtering the cases. For example, I guess Dr. Ibtihal mentioned that there's sometimes delayed in reporting because of lack of radiologists. Probably we can use AI to filter the urgent cases and start working on this one and maybe postpone the less urgent by the AI, for example. This is one issue. You still have to do the diagnostic workup, but you have to always do it with the ultrasound, with someone doing it with manually with his hand. Then you have to do the intervention. So artificial intelligence will not replace radiologists, but I think like it will not be the magic tool to solve all the issues. But it will be a very helpful tool, I think, down the road, because it started long time before other forms of AI, and there's lots of data already used for the AI to learn how to read the mammogram. I think it will be helpful to use it in our workflow to facilitate, to help the radiologist to classify the cases. This is what I think about AI.
Yeah, thank you. Dr. Lamia, that given your background, the health system, now, like for child health, we always can identify on the system the missed opportunities. So you help the person in the front liner when he plan to reduce these missed opportunities, to plan well, I mean, to address this. So for women health and well-being, how you see the missed opportunities, how you see the contribution of the head of health service facility or lower level, district level or state level or whatever to plan for reducing this?
So I think planning, we need to look at where women enter the health system and why they come to the health system and use those opportunities. I think that the best known opportunity to all of us where women come is when they come for antenatal care or postnatal care. And these are critical times where we can catch women and do the required counseling, give them the required information, and inform them, where they can find the services. I think, again, one of the critical challenges for women is where do they go and where do they find the services, giving them all that information about the behavioral risk factors and so on. We can still capitalize on the opportunities when they come for treatment for other causes in the health system, and therefore healthcare providers, as I mentioned, have to be tuned and aware and ready to take those opportunities to deliver the right messages. We also know that, so for example, some countries have a certain target for clinical breast examination. So they want to ensure that, for example, 10% of women who come to the health facility, the care provider will conduct clinical breast examination for 10% of women, for example. But then often you find that the care provider sitting in the health facility doesn't even know that they're supposed to work towards that national target. So there's also this disconnect between the planning that happens at national level and the care providers that are sitting there actually delivering the care. So constantly informing them, sharing information about targets, even clinical information, how they should do the clinical breast examination, how they should document what they're doing, all these things. And then the accountability piece, of course, to ensure that care providers actually do undertake what they're expected to do and do take opportunity of women coming to their health facilities.
So now the model of King Hussein, you have a multidisciplinary kind of work, serving your clients, addressing different specialties that is needed to ensure the quality of care. So when it comes for psychological support, counseling, and for the patient and beyond the patient, for the family, we know, I mean, when the family went through the experience of diagnosing cancer patient. So how can Hussein provide the service?
There is actually a psychosocial program established at the King Hussein Cancer Center, and it has really improved significantly over the past years also. So any new case admitted to the center as a cancer case, it will go immediately to the first so-called social work office. And they will evaluate her social condition, like if she's living alone, she's living far away. So they can even give some support to providing accommodation when they come. If they are outside the capital Amman, some hotels or something. They can even support financially if they need some certain cases. Now, this is the social part. The psychological part, there's a psychological assessment clinic now. Almost all patients are seen at some point in the psychology clinic, and they can be referred. We have psychologists and we have psychiatrists. Also clinic. So any patient has complaints, she will be referred to the clinic there to assess. And if the family members there are also any part of the team can come to consult with them. And this is mainly for the pediatric cases, for example, with coming with their children, they will sit with their parents, talk with them. And for the adult services, which like the breast cancer, the women themselves, they can go to the clinic themselves. The family, they can be part of it whenever is needed for counseling. And we have also the supportive group, like the woman survivor, the breast cancer survivor, who come regularly and give support to the woman. And these have really good feedback on the newly diagnosed cases or during the treatment, because they see in their real eyes, in front of their eyes, that they are survivors from the breast cancer. So that's why they are, maybe they have more influence on the woman than any other one talking.
Okay, thank you, Dr. Leila, for that. But I think in the majority of our health service, if we provide the service, the component regarding counseling, we give more attention to the patient. However, building this supportive environment, I think this is an area where we need to exert more effort on that. So it's provide a continuous care for the patient. to overcome this challenge of especially when they are newly diagnosed. Dr. Lamia, you mentioned that there is a gap between planning and the capacity of health worker, right? So it's a matter of capacity where they don't know, or it's a matter of accountability and performance raising on what they do or post, and how can we improve this?
To be honest, a lot of times, but I must say that this is not with a sample. This was just when I do routine, during missions, visits to health facilities. I ask care providers, do you do this? Do you do clinical breast examination? And I've been met with very blank looks when it was obvious they weren't aware that they were supposed to do it. So I think it's about communicating what's in our strategies and plans at national level to those who actually implement on the ground, and making sure that they remain accountable with certain KPIs, certain monitoring tools, and incentivizing them to do that, letting them know that when they actually do this, it doesn't have to be monetary incentive, but it could be recognition that this work is actually being done.
So thank you for that, and thank you for this insightful reflection. I think it's during this webinar, we went through seeing the burden, seeing the strategies, seeing what's delivered recently by WHO to guide the health policy at the national level, but also we saw the power of the community and how they influence, contribute for the service, for the awareness. And also we saw the King Hussein Center, where the model of care that recognized not only at the Jordan level, but it's also at the regional level at one of the best centers of practicing care for patients. And also I think Dr. Lamia, also we need from your position at the regional level to create this networking, sharing of experience, despite the variety of capacities of the country and the resources available, but also the standard, the model could be applied even in a low context thing. I think like a final words before closing, both of you and also Dr. Ibtihal mentioned the challenging situation in the region, and that now we have women with cancer under emergency. So a few things that you can just reflect on that. What other effort that we can do before closing? I mean, the floor for you, just to comment on few words on that. Pause. Dr. Lamia, you can start. Dr. Layla, you can complement here.
So yes, just to thank Internet and to thank you, Nada, for the opportunity. I think it was a great chance to share certain insights, but also to learn from the other speakers. I think there's still a lot that needs to be done. We have an initiative that guides us, it tells us how to do it. We have WHO produces a lot of technical guidance, as I've mentioned. You'll find it on our website, the global initiative, the framework for the global initiative. I don't know if you can see it. We have the guidance or the guideline on patient navigation that just came out last week. There's lots of guidance there, and the more we unify the way we do things, the better the outcomes for us and for the patients. Just again, re-emphasizing that no woman should face breast cancer alone. Let's all join them in the fight, their struggle, and support them in the best way we can. Thank you once again, and we look forward to continuing the effort beyond Pink October. It doesn't end here. We're actually just starting.
Thank you. Dr. Leia.
Thank you very much, actually, for Infinite, and it was really very nice discussion and meeting from these different perspectives that we usually do the clinical work, as I said. One last word, I like to emphasize the role of primary health care, which I really like to convey this also in Jordan now. After we have spent a great journey, we need to emphasize the primary health care in facing the woman at the beginning to facilitate early diagnosis and then the screening, because they are the first encounter. And as you mentioned that women facing cancer now in our situation, in the region, like in Gaza, in Syria, we have, we have refugees come for Syria in the north of Jordan, Zatari. This is actually a struggle. I think this has to be done at higher levels, how to help these women with their cancer cases once they are diagnosed. We have limited efforts. We have now some mobile van, one of the Zatari camp in the north, but some cases are diagnosed with cancer already, and this really needs more effort. Probably this, how we can help this woman, for example, how to provide for them this diagnosis and then treatment once they are diagnosed with cancer. I thank you very much again for inviting us for this event. Thank you.
Thank you for your presence. Thank you for these valuable inputs. And I just a few words from Infinite's side, although I am a moderator, but also we focus a lot on PHC. And I just echo your words. And there is a multiple initiative that Infinite is doing in relation to PHC, especially promoting the role of health team. So it's another model of multidisciplinary, but at PHC level. And I think this could contribute, if applied in the country, in also like providing the comprehensive care as needed at PHC level, but also having multidisciplinary will enhance limiting the stigma. It will help in creating demand and handling the needs and maximizing the benefit for the patient. And I think also there is a lot of effort that could be done in research side and sharing the data and showing the case or what we are doing in the region. I have heard before of a lot of presentation on scientific paper on finding, especially when it's a specialized center, but I think also at primary healthcare, we need to show some evidence on the impact and effectiveness of what we can do efficiently at primary healthcare. So thank you for your presence, for your contribution. I really enjoyed the discussion. And I hope we contributed with adding our voices to this awareness month, that definitely we will continue doing this beyond this month. But it's the month of hope that we can get better outcome whenever we invest in cancer prevention and early detection and quality care. So thank you. Bye-bye.
Thank you very much. Thank you.
Thank you.
Thank you.